opinion with us today is improving clinical outcomes at affordable costs with technology is fast becoming a reality. Will you be left behind? This expert opinion comes from Stasis Labs. May I please invite Dr. Roheet Rao, Head Clinical and Business Development, to come and give the talk. Thank you.
I'm Dr. Rohit. I lead the business team at Stasis, and today really what I wanted to talk to you guys about is the era of affordable clinical excellence is upon us. I think the panel set the stage very clearly. Healthcare landscape is changing a lot. Now, are we going to keep up with it, or are we going to be left out? Now, the purpose of my talk here, I'm going to keep it short and crisp, because I really want to hear more from the audience than speak myself. But let me just get down to it and tell you why today is the opportune moment for us to be exploring, for example, cost optimization. Not cost cutting, cost optimization. Better return on capital. How do we achieve those things? Now, those are the questions that are extremely relevant today. And the reason they're relevant is because top line growth has always been hard, but it is now becoming harder. You have caps being put on your stents, you have knee replacements being capped, policies being implemented, the regulatory environment is changing where care delivery has to be optimized. Your revenue growth is going to struggle. But at that same time, your costs are increasing. Now, if you look at the input costs, they're spiraling. 40 to 50% is your manpower cost, 30 to 35% is your material cost, 15 to 20% is your overheads, and you have replacement capex on top of all of that. Now, if we just look at what's been happening over the last 10 years, your manpower costs are going up year on year. You have especially in Kerala, with the nursing minimum wages being set, it's a big impact. In fact, nurses are the largest community in a hospital, right? There's almost about 2.5 to 3 nurses per bed that you need across a hospital. Now, you do the maths. With a single policy like raising the minimum wages for nurses, your costs are going to spiral out. If you look at your material costs, year-on-year increases, as expected, overheads are going up. Your cost of doing business in the market, on an average, 7% going up. This is from an EY report that was published. And obviously, your replacement capex, 5% year on year, that you have to put in no matter what, because you've invested in that capex equipment. Now, the final piece of the puzzle here is the payer profiles changing. We are moving to an American model where insurance penetration is going to be high, and you're moving from a fee-for-service to fixed cost packages. Gone are the days when cash patients would be subsidizing your package patients. Look at that graph there, and in 2020, it's projected that your TPA and insurance patients are going to far outstrip your cash. This is why it is the opportune moment to be looking at, introspecting on what your cost systems are, where your buckets, what is the optimization that you can achieve here. And one of the, I really love this analogy, it's the boiling frog. Now, frogs are cold-blooded. So when a frog is sitting in a pond and you increase the temperature in small increments, the frog automatically adjusts to its surroundings to a point where the water could be boiling and the frog is boiled alive because it's not realized that temperature has changed so much and it has adapted. So do you want to be the boiling frog? The environment around you is changing rapidly on a daily basis, small increments, capping on revenues, increased costs. What are you going to do about it? Are you going to sit in the hot bath, or are you going to be jumping out and figuring out how you solve this problem? Now, because I work with a healthcare technology firm, my core belief is that one of the key ways we're going to achieve our goals today in healthcare of being able to deliver great clinical outcomes with affordable costs is through technology. It's not the only solution, it is one solution. And let me put this in context. How do we assess technologies? There's so many things that are coming up today. You have AI, you have ML, you have IoT, you have remote monitoring, you have OPD solutions. Every part of the hospital has some tech concept that is being explored. Now, as providers, as the people who are end customers for this technology, how do you really evaluate it? One aspect that I want to introduce is the Gartner hype cycle, right? So typically it goes through a peak of expectation where people believe that AI is the next solution. Then it goes into a trough of disillusionment when things don't work. And then it eventually gets to a plateau of functionality where use cases are defined, there's enough data, and then you can adopt technology very safely to say, yes, I know these are the outcomes, I know this is all the studies, I know this is all the case studies that are available for me to look at, all the data that's available to me to look at, and therefore I can now adopt it. Now, typically your early adopters are the ones that are going to benefit most in the early days because they're willing to take that risk. The mainstream adopters pay a premium because you're looking at a well-developed premium solution by the time it gets to a point where it's fully validated. Now, where are you going to be? That is the question. Are you going to be an early adopter, take a measured risk? Are you going to be a moderate who waits till you have some cost-benefit analysis, till you do some small pilots? Or are you going to be a late bloomer where you've lost the entire hype cycle entirely and now you're dependent on implementing a premium technology or being left behind? I really want everyone in this audience to think about this. Do your homework. Do your cost-benefit analysis. Don't be afraid to run pilots, because that's where you get an understanding of how that technology is going to impact you. And today, there are so many solutions available that are willing to come and implement in the hospital. Can you create an ecosystem that is going to nurture these systems? I want to leave that thought with everyone in the audience today. And I'm actually here to introduce to you what is going to be, for the first time in India, Stasis is going to be opening up a smart hospital program. We're in open beta, and our premise here is to bring affordable AI to the bedside. MD Anderson last year benched IBM Watson. They spent $50 million implementing IBM Watson over 18 months and then benched it. IBM Watson was the forefront of healthcare AI. But can any hospitals in India afford it? Is it relevant? I know of one hospital that has. I don't know what the impact has been. The premise of Stasis has been around bringing affordable technology to hospitals and democratizing AI, democratizing machine learning. Because India is a slow-moving, low-margin mass market. We work on volumes. And with volumes, we can flourish on an AI and a data, on a data platform. And if we're not going to be able to leverage that today, we will never be able to get to a point where care can be delivered to 1 billion people at an affordable cost. The panel prior to this, was talking about sustainability. This, ladies and gentlemen, is sustainability. Think about, I want to walk you through very quickly what the program is. Really, I want to hear from you what your responses are at the end of this conversation, which is why I want to keep it quick and I want to open it up to conversation. What is a smart hospital? We believe that smart hospitals are hospitals that can improve quality with minimal CapEx costs, minimal investments. How do we do that? Now, Stasis, the vision in itself is to protect vulnerable patients across the hospital using affordable AI. And as part of the program, we convert 20% of all hospital beds, be it in the HDUs, post-ops, emergency ICUs, in the emergency care, transplant care, et cetera, into smart beds. Now, the purpose, overarching purpose, is reducing cost of delivering care so that you are moving from a scenario of trying to keep margins high and keep costs low to adjusting it for your cash and your package patients appropriately so that with your package patients increasing, you're able to maintain and deliver the same level of care that you would have. Cutting clinician cost is not an option. You want star clinicians, you want clinicians who have best clinical outcomes at your hospital to be delivering the care. Now, how do you enable it? There are several aspects to it, and one of the concepts that we have come up with is the smart hospital concept. We deliver this on 3 phases. We first implement smart beds across the hospital. The key aspect where technology fails in most hospitals is with implementation. So we actually act as implementation consultants. We will help you in phase 2 to implement the solution across your hospital. And finally, the fruits of the labor are going to be realized in phase 3, where we drive patients to choose smart care because it's in their best interest. You're not paying more, but you're getting the best clinical outcomes. That is our goal. That is the vision. And that is what excites me about being in India in the healthcare sector today. So how do we create smart beds? I want to walk you through this very quickly. We have a bedside system that collects all of the data, no nurse required, apply the standard probes, data starts streaming in. We then centralize the data with a tablet, so the nurse at the nursing station is able to visualize all of the patients in her ward, assess what their level of risk is, figure out who needs more care and who's doing okay. And all of this is then pushed to the Stasis cloud, which allows clinicians from anywhere in the world to access that patient's data, check up on their patients, and make sure that they can, virtually ensure that their patients are safe. So what does this actually mean? This means being able to get the right data to the right stakeholder is a key aspect that we work on. At the bedside, we have a monitor that is silent, that only shows you pre-interpreted color displays. So even a lay person knows green is good, yellow is bad, call a nurse. The nurse, on the other hand, is only looking at a centralized tablet. She knows exactly how all of her patients are doing because we do automatic early warning scores. And the clinician, who may be anywhere, might be checking up on a patient in the district hospital, sitting in a metropolitan city, is going to be able to see very quickly how that patient has been doing just by opening up our app. We do automatic trending, we do automatic EWS scoring. We even tell you which vitals are in range and out of range. And in fact, we've gone a step further, and we have now put live vitals on clinicians' smartphones. So at the touch of a button, a clinician can actually look at the ECG trace of a patient who is on stasis. This is delivered to our clinical community. We help triage your patients very quickly so that you can conduct virtual rounds even before you're in the hospital. You can save time by checking up on patients who really need your care. We put live vitals on their phone so that they can diagnose these conditions remotely. And the final piece of the puzzle, your democratic AI comes in here. So we have machine learning algorithms that run on the background that tell you 15 to 20 minutes before a patient deteriorates. You can see the live vitals of that patient, everything's okay. But our AI is learning on almost 70,000 hours of data that we've collected so far to push smart alert notifications to our clinician. They only say, check up on this patient, there's a greater likelihood that this patient might deteriorate. On the flip side, we also tell clinicians that a patient is stable. And why do we do that? Because as a smart hospital, you need to churn through patient volumes. You need to optimize your lengths of stay. You need to ensure that your package patient costs are low. And how do we do that? We give you stability graphs which tell you when the patient is stable, and the AI tells you, hey, this patient is stable, the care can be reduced. Maybe that patient can be discharged. Maybe that patient can be pushed into the wards. We deliver end-to-end care for these smart beds. when you implement smart beds with Stasis, you do not have to worry about AMCs and CMCs and calibrations. You're not paying for that. That's not part of your replacement CapEx. Broken probes, don't worry, we'll fix it. We'll come in, change it out. Damaged monitor, that's actually coffee being poured on the monitor. That doesn't happen in the hospital. But damaged monitors, we take care of it. We're service guys, we're not retailers. We provide a service. And that service is building a smart hospital. No Wi-Fi, put a SIM card. So we have built a system that can be deployed, that is plug and play, can be deployed at your district level hospitals. At the same time, it can be put in your posh patient rooms in your tertiary care hospitals. Same system. The end user is very different, class versus mass, as you were saying. What we do is essentially democratizing healthcare in a way that is affordable to everyone and beneficial to the care providers. Server maintenance, Stasis Cloud is there. Why would you want to spend money on IT when we can do that for you? And I think this is the critical piece of the puzzle where most technologies go to die in the implementation phase of things. And we help our partner hospitals implement this program in a very clear way. We have a 90-day customer success program, which is the intensive phase, where we do nurse trainings, where we do clinician CMEs, we do consultations with clinicians to understand to get them on the solution, use the solution, get feedback from them straight through the app. We have a nice welcome kit to inform everyone that they're part of the Stasis movement. We have a clear SOP-driven process to ensure that every specific department of the hospital that needs to participate is participating. And that's taken through with our customer success managers who are going to be on site and delivering this service to you guys. We craft SOPs for hospitals. We sit with their key clinicians and say, hey, which patients do you think require this level of care? Not every patient in the hospital requires it. You can get any number of wireless patches, but they will not improve your patient's safety simply because you don't identify the right people who need to be on those wireless patches. 100% of patients on patches, not a good idea. You will have so many false alarms that the nurse is going to go mad. We have a comprehensive nurse training academy that upskills your nurses on using technology, on interpreting technology, on being able to just be comfortable going paperless, right? Like they don't have to do any collection, they don't have to do any documentation, they are just delivering care based on what they see. And we celebrate success together. At the end of the 90-day program, we have a Stasis launch party where all the clinicians come together, all the people who have helped us put these SOPs come together. And we all celebrate the fact that we've been able to do that. And I think celebrating wins is a huge part of our company culture, and we want to bring that to hospitals. We want nurses, paramedical staff to feel like they are part of the system, part of the movement. And that's when you get lower attrition rates. That's when you keep your skilled staff. And we do that for you. And finally, the cherry on top, how do we get patients to realize this? So we have a year's sort of marketing plan with the hospital that we run in conjunction with your marketing departments. We have press releases that go out routinely. We do patient testimonials. We take success stories from your patients and tell your peers about it, tell other patients about it. We profile your star clinicians. We get them to be thought leaders. We bring press around them. We bring, we disseminate their stories of success pan-India. We profile your success amongst your peers to create a powerful brand. We do academic publications with our clients. And we, spread the word locally. That's where your patients are coming from. Why should they not know about how well you're doing? Why should they not know about the care that you're providing them? So this is an all-encompassing plan that we run as part of the Smart Hospital. And if you're asking, what's the precedence for it? It is today achievable. Here's a quick case study. 470 patients that were pushed through the stasis ward at one of our partner hospitals, and only 12% of them required actual ICU level escalation. Previously, all 470 would have gone straight to the ICU. We said, wait, test whether you really need these patients in the ICU. If not, put them in the stasis ward, monitor them continuously, monitor them remotely, have all this data available to you, and when you have a clear indication, push them into the ICU. Using that principle alone, we were able to reduce ICU burden by almost 88%. 88% reduction. And what did this mean to the rest of the population that went through the stasis system? We eliminated code blues in the wards. 2,300 patients treated this year. When we took this data, 0 code blues, as opposed to 1 in every 600 patients before. And we deliver operationally what you're looking for. You want top-line revenue growth. You want cost optimization. We provide you that opportunity to do that today. ICU occupancies at our partner hospital, again, continuing with that same case study, remain the same. In fact, the patient referrals outside because of unavailability of beds reduced by 80%. That's a straight benefit to the top line. RPOB on the beds that were stasis beds, 20% higher, because patients who are sitting in these beds are actually avoiding ICU level care unnecessarily. In fact, we reduced the bill for dengue patients by almost 80% during dengue season, simply by having this additional level of filter where only those specific dengue patient populations that really required ICU level care were escalated to the ICU level care. In fact, the difference is so stark that it was the reduction in ICU admission for viral bradycardic fevers was down 60% with stasis. Previously, if you had 100 patients last year sitting in your ICU beds, and these patients are stable, they're sitting in an ICU bed, you cannot have a high-cost bed like that being utilized for someone to just sit there without any interventions just because you're not confident about them being in the ward. That is a smart hospital where you're optimizing your care levels based on acuity and ensuring that you're segueing patients through the care pathway optimally. Dr. Pillai used the word lean. This is lean, ladies and gentlemen. This is lean. We provide a low-cost, high-acuity bed which generates 2/3 of the revenue as an ICU bed, but costs the same as putting a regular bed in there. We optimize nursing levels from 1:3 in an HDU scenario to 1:5. Why were we able to do that? Because we automated, because we removed that from a nurse's requirement. She's no longer writing out notes. She's no longer documenting numbers every hour. She's no longer having to take BPs. Everything's being done for her. And she gets the benefit of an affordable AI where she knows if she has to respond to a specific alert on the tablet, she feels safe that she can manage these high acuity patients in a ward scenario. Low cost, high margin beds. That's where the future of hospitals is, and that's where it has to be if you need to deliver low cost healthcare with great clinical outcomes. And it is possible. We reduce that CapEx block for you. We optimize your manpower numbers. We reduce the high attrition that you have with nurses. We want to eliminate that. We want you to stop spending money trying to hire skilled nurses at 30% attrition. That's a cost. That's a hidden cost. That's where your lean breaks down. This is the low-hanging fruit for you. And finally, zero CapEx, just to sum it up, no minimum usage. We don't insist on it. An implementation fee because we run you through the 12-month program to actually implement this smart solution. And it costs you less than 100 rupees. less than 500 rupees, including GST per patient managed. And the final piece of this is where we really pride ourselves on the fact that we continue to innovate and give you those innovations. You don't pay for any of these new things that are coming up. We're building out the Stasis Smart Alert. Everything is going to be rolled out to the Stasis network. We're going to be coming up with an outpatient mode that lets you seamlessly integrate this in various, not just the IP, but also in your OP areas. We have patient portal integration to ensure that patients seem involved. Patients know what's happening. Their loved ones can, at the click of a button, know exactly how their patient's doing in the HDU. And that is what patients want. They want to be part of the care system. The trust deficit comes when there is lack of transparency. We implement that transparency as part of the smart hospital solution. And finally, getting your GPs excited about sending patients to your smart hospital. That's a big value prop that you spend a lot of marketing money on today. We will help you do that. So that's pretty much the end of my talk. In conclusion, we are looking for partners to take on the mantle of smart hospitals with us. We have very limited resources, so we select our partners very carefully. We look for intent, and we look for a partnership, not a retailer-vendor relationship, but a true partnership where we build a solution together. I'd love to open up the floor to any questions.
How does it cost?
Under 500 rupees. It's pay-per-use.
Per bed?
Per bed, yeah.
Per use, or you have to buy?
It's per patient.
Per patient?
Per patient.
That whatever you sell.
So let me explain the commercials. There's an implementation cost for the first, when we run the customer success program, the first 3 months, we put all the infrastructure in place, get the units in, get the nurses trained, get the BMEs trained, give them all the materials that they need to go live with it. Once that is done, on a per patient basis, the hospital pays. And that's under 500 rupees. Per patient. Per day. So you're charging your patient, X amount per day that they're spending on the bed. It depends on the scale. So I think we can chat about it afterwards. But let me tell you, for a 25-bed installation, we're as cheap as 2 lakhs. 25 beds.
Minimum guarantee?
Guys, 25 beds.
Is there a minimum guarantee?
There is no minimum usage. There is no minimum usage. But we help you implement and drive usage.
Legal implications of this?
I mean, we have 25 clients today. We have Fortis, HCG, Columbia Asia's all using the solution. So I'm happy to put a reference, and you can ask them why, how did you get around any legal challenges. Honestly, we've done the vetting ourselves. There isn't any, because our app is customizable entirely by the clinicians. If you don't want notifications, you can turn it off. It's mostly your registrars, residents, junior consultants, on-call doctors who use that. And that app has been customizable to let you be on duty and off duty so that you're not getting any notifications when you're off duty.
Is there an upgrade cost for this?
No, I'm glad you asked that. For every hospital on the Stasis network gets the upgrades that we roll out every 6 months. And as I told you already, we have AI that's going to be rolled out in open beta today.
Key question.
Sure.
Actually, you are using this data to build your AI, right?
Correct.
So actually, you should pay the hospitals.
Well, what are hospitals doing today with the data that they have?
That is a different issue.
Patients giving you the data as a hospital.
Yeah.
Do you pay the patient for the data?
Actually,
The
we should reach that
hospital is
level.
using
We should
the
reach that
hospital
level.
is using the data for optimization of care. Do you ask the patient to pay for it?
But the issue on the other side is actually, if you can say there is a subsidy of that particular thing is happening, if the hospital is truly using the data. But this is,
Data is worthless. Insights are what are useful. So we spend money on building a data science team that is going to make sense of the data.
But
you can hold all the data that you want today and do nothing with it.
But I feel that that thing also should be informed to the people, because this data is going to be used for artificial intelligence.
Well, we don't have any patient details.
But the people do very paranoid and sensitive, because
yes, we'll
this
tell
is
you.
not the first time.
We'll tell the patient, hey, look, why do you think you're sitting in a bed which is AI powered and only paying 500 rupees? Because all of your data is going to be anonymized, no identifiers. It's, some machine is learning about how your trends look. We can't go back. If we are subpoenaed by someone for data, we can't go back and pick that person out because we have anonymized it. We don't have timestamps, we don't have location stamps, nothing.
I have a privacy question.
Yeah.
In terms of the privacy, is this data, I understand that it is put on a self-learning algorithm, and the self-learning algorithm loop is only for that particular customer, or you are going to have a comparative self-learning between
as long
clients?
As that patient is live, as long as that patient is on the system and live, the only decryption that happens is at the nursing level, where she needs to know which patient what data belongs to which patient.
I'm talking about client to client.
Yeah.
So I'm in Fortis.
Yeah.
Okay. One set of app is working on Fortis. The second set of app is working on Columbatia. So, are you doing a self-learning algorithm between patients, comparative algorithm
Well, it's
between?
Oh no.
I have my privacy of mind.
We don't. Look at it this way. We have several pots draining into one pot. We don't know which pot it's come from.
So it's getting streamlined into one algo.
Yeah, the algorithm is just looking at numbers.
Numbers, not on client.
It's not looking at where, how, when, who.
No. I'm asking, is the algo is running for individual client or as a common for all clients?
It runs on our cloud.
All clients.
Yes.
All clients.
The Stasis network. Yes.
Yeah.
And there's a new, to really respond to questions like this, we are now exploring something called federated machine learning. Not sure how many people here know what that means, but essentially you decentralize AI. So rather than it being on the cloud, our monitor and our tablet at the site with no connection to the cloud is going to start running ML algorithms. So at that point, we don't see the data, it's just running on our systems at your hospitals. So that's a new, it's in our 6 to 8 month roadmap, and we're going to be rolling out federated AI. I think Google already does it on your Gmail, on your G Suite, where it tells you, right? It tells you, hey, you haven't followed up in 4 days. Do you want to follow up? That's federated machine learning. That's telling you, hey, listen, you sent an email. Do you want to follow up on this email?
So I think, I will close it at this. He's available here throughout the day. This is one of the, ways of cutting cost. We've had that session. So it's good that he followed it up. And he himself is a doctor. So I think he understands the technology quite well. He's done his master's from England. And he's worked with one of the big fours as consultant. So he understands the responsibility of the product that comes.
I was, in fact, part of the EY healthcare team that did performance improvement hospitals that's currently in Asta, the same team actually. And our focus was cost optimization. So I did, cost optimization for manpower, for material, supply chain management, all of that. And that's part of how I bring value to Stasis, really. Like my, bigger goal here is how do we improve healthcare? And which is why I wanted to keep the talk really open.
Yeah, I can see the passion, flowing through. So I think welcome to the, but there are many like, you, Dr. Harish, Dr. Chandy, Vijay is here. There are many more that you are going to hear. So I think with this, many thanks, Rohit.